Welcome, everyone. Thanks for joining. We'll be getting started soon. You'll see a couple pop-up questions on demographics, so please go ahead and answer those while folks are signing on, and we'll get started soon. Okay, I think we'll get started. So hi, I'm Al Liu from the San Francisco Department of Public Health. Thank you so much for joining our webinar today, The Art of HIV and STI Prevention, Update from CROI 2025. I'll be moderating our session today with our presenter, Dr. Susan Buchbinder. Before introducing our speaker, I'd like to go over a few introductory comments. Next slide. So these are disclosures for the content on the web board. Next slide. And these are disclosures for Dr. Buchbinder, myself, and our reviewers. The IAS-USA designates this live activity for 1.25 CME credits. And the webinar is also approved for 1.25 hours of ABIM MOC points and nursing, pharmacy, and pharmacotherapy credits. Generous support for this activity has been received from the contributors on this slide, but they have not had any input into the content of this program today. And during today's webinar, there'll be several poll questions, which will show up as a separate pop-up window, and you can go ahead and select your response. Also, at any time, you can submit questions using the Q&A button, and we'll try to get to as many of the questions during the Q&A session. And please include your full name and institution when asking a question. Also, at any time, the chat window is open, and you can chat with other participants, but please include your questions in the Q&A. And so now I'd like to introduce our speaker, Dr. Susan Buchbinder, who I've had the great pleasure of working with over the last 2 decades. She's the director of Bridge HIV, which is an HIV prevention research unit within the San Francisco Department of Public Health. And she's also the clinical professor of medicine, epidemiology, and biostatistics at the University of California, San Francisco. Dr. Buchbinder is also one of the founding members of, and now serves on the steering committee of San Francisco Getting to Zero, which is an initiative aiming to eliminate new HIV infections, HIV-associated deaths, and HIV stigma. So Dr. Buchbinder has really been an incredible leader in the prevention field, and we're really excited to hear your talk on what's new in HIV and STI prevention at CROI this year. So Susan, I'm going to turn it over to you.
Okay, thanks so much. So hopefully this is in the right view mode, and I'm just going to get a laser pointer so I can point out some of the data that I'm going to get ready to share. So these are my disclosures. You've already seen those. And these are the learning objectives. We're going to describe the current approaches for HIV prevention, describe new data presented at CROI 2025 and how they affect HIV prevention strategies in the clinic. We'll talk about Doxy-PEP for prevention of sexually transmitted infections, and then we'll talk about some novel prevention approaches under evaluation. So this is the first pretest question. According to data from the IQVIA commercial prescription database, approximately what % of oral pre-exposure prophylaxis users in the US in 2021 and 2022 persisted on daily PrEP use for at least 6 months? Go ahead and choose. Okay. We'll come back to that question in just a little bit. The second question is, of the 47 participants in the HPTN-083 study in men who have sex with men who were exposed to long-acting Cabotegravir but who became infected with HIV, what proportion achieved viral suppression on their first antiretroviral regimen? Go ahead and vote. Great. So I will come back and show you the answers to those as we go through the presentation. So let's go ahead and move through the presentation. This is what I'm going to start with, is HIV epidemiology in the current landscape. We'll talk briefly about HIV testing, move to talking about PrEP rollout and new PrEP regimens, and then close by talking about STIs and Doxy-PEP. So HIV epidemiology in the current landscape. This is data from the World Health Organization, or from UNAIDS, sorry, and it shows that although new diagnoses have been coming down, we're really far off of the 2025 target. We had 1.3 million new infections in 2023, and our 2025 target is to have less than 370,000. So we really need to do quite a bit to get there. And Chris Beyer did just a fabulous plenary that I really encourage you all to watch, in which he talked about this and talked about where we are in the current epidemic. What you can see here is that now slightly less than half of the new infections are occurring in Africa, in East and Southern Africa and West and Central Africa. And you can see on the right, this is the change in new infections between 2010 and 2023. And they've gone down substantially in those two regions of the world, but they're actually increasing over that period of time in Latin America, Eastern Europe and Central Asia, and the Middle East and North Africa. And then what you can see here is that PrEP has really taken off, particularly starting in 2022, 2023, 2024. But 91% of the global PrEP that's being administered is coming through PEPFAR, the President's Emergency Fund on for AIDS. And that what we know is that January 20th, all foreign aid was frozen for 90 days. Now, it was supposed to have been lifted for PEPFAR, for at least parts of PEPFAR, but since UNAIDS, since USAID was the one that was actually administering PEPFAR for the most part, it really hasn't been quite functional since that time. It was in the first week after the freeze went into effect. You can see how many functions were either reduced or completely canceled because of this freeze. And it was estimated that there would be 220,000 people per day, including over 7,000 children, unable to access needed treatment. In the first month after the freeze, it was estimated there would be 3,600 new adult infections, and that in the 4 years following, there would be 8.7 million new infections, 6.3 million AIDS deaths, and 3.4 million AIDS orphans. So really a substantial negative impact from this foreign aid freeze. And then these are data on the US, closer to home for those of us who are in the US. And you can see that while we've seen this decline over time from 2010 to 2018 in white individuals, in Black individuals, we're seeing that there hasn't been a substantial decline. And this is for men who have sex with men. And so this was something else that Chris Beyer pointed out, is that we have real problems here in the US. So let's turn to talking about HIV testing, and then we'll talk about what we can do in terms of reducing new infections through PrEP. So this was data that looked at what proportion of the nationwide need for HIV testing could be filled from this CDC Together Take Me Home project, in which free home test kits were mailed to people who requested them. And these data come from March of 2023 through July of 2024. You can see in this analysis, there were over 300,000 orders in all 50 states, including the DC, Washington, DC, and Puerto Rico. And what they did was they estimated the need based on the behavioral risk factor surveillance system, which estimates that 5.4% of US adults had an elevated risk for HIV in the past year. And of these, 50% never HIV tested, and 68% hadn't tested in the past year or ever. What they said was that this program alone met 2 to 4% of the need in Wyoming, the lowest range, but up to 21 to 40% of the need in Washington, D.C. And you can see the darker, deeper colors are the meeting greater need. So you can see the areas of the country where particularly we were meeting need. And that's particularly important because we've got a substantial epidemic in the southern U.S. And then there was another presentation on this home testing order, which had almost 300,000 orders in it. There was quite a bit of diversity in terms of race, ethnicity. 25% had never tested, and 25% had tested, but it had been more than a year. And of the about 10,000 people who were both tested and answered a survey, there were 182 HIV positives without previous evidence of infection. 107 of those went on to test by a provider, so about 60%. 67 of those were positive, that was 63%. 12% were HIV negative, and 7% were indeterminate or unknown. And of the group that was positive, 75% initiated antiretroviral treatment. So it was really capturing some people who needed to both to know that they were living with HIV as well as to get onto treatment. But we need more efforts to get rapid linkage to care. So let's talk next about PrEP rollout. This is some data on suboptimal laboratory testing of PrEP users in the US from 2022 to 2023. Now, for PrEP users, the CDC recommends that there be HIV laboratory-based testing at initiation and follow-up visits, that at initiation and follow-up, STI testing happen, that hepatitis B testing happen at initiation, and that creatinine testing happen for oral PrEP users. And so in this analysis, they evaluated market scan database for those starting oral PrEP or CAB-LA in 2022 to 2023. Of more than 35,000 oral PrEP users with more than 12,000 follow-up prescriptions, you can see only 38% had laboratory-based testing for HIV prior to starting. And for screening, only 56% had laboratory-based testing. So presumably these people were getting rapid tests, we hope, at least that, but there's greater sensitivity from the laboratory-based testing. And so it wasn't achieving what CDC was recommending. In terms of CAB-LA, the numbers were a little bit better, but still not as high as they were expected to be. Only 55% had lab-based testing at initiation and 82% at follow-up. And then you can see in terms of hepatitis B, syphilis, chlamydia, gonorrhea, and creatinine testing that they also were, particularly at initiation, below the levels that they were expected to be for both oral PrEP and CAB-LA. In terms of how we're doing with rural PrEP users, this was an interesting presentation in which they used, again, IQVIA real-world data. There were over 470,000 urban PrEP users who received PrEP from over 86,000 providers. 59% of those received PrEP from a physician. And urban users had to travel a median of 6.2 miles to receive their PrEP. On the other hand, the rural PrEP users, over 28,000 of them and over 16,000 providers, 56.3% received PrEP from a nurse practitioner or physician's assistant, and they traveled a median of 39 miles to get to an urban provider or even 36 miles to get to a rural provider. And so distance and providers may be barriers, particularly in rural areas. And so we need to consider telehealth and local pharmacies to dispense PrEP in those settings. So that was, I thought, an interesting poster presentation. Here we come to the first audience response question that we asked, which was, what is oral PrEP persistence like in the US? And again, they're using the IQVIA commercial database. They defined PrEP persistence as continuous PrEP for at least 30 days. And what they found was that non-persistence was more common in women, people at a younger age, Black and Hispanic, and other race and ethnicities, public or cash payment, all of the regions of the US compared to the Midwest. And in 2021 and 2022, it was actually worse persistence than 2017 to 2022. And so the correct answer to that was only 40% of new oral PrEP users continued to 6 months. It doesn't take into account if people were using 211 or if they switched to Cab-LA, but those are probably a minority of the individuals who were using PrEP. So we do have an issue with PrEP persistence over time. Now, we also know that young men who have sex with men have high HIV incidence, and challenges with PrEP adherence are common. And there was a prior study in Kenyan women of using a urine point-of-care tenofovir test, that when women were counseled about their tenofovir levels, showing them that using that urine point-of-care test, it demonstrated improved long-term PrEP adherence. And so in this analysis, the question arose, could that work for young men who have sex with men? And so this was a study of 49 US men who have sex with men under the age of 30 who were randomized 2-to-1 to either get this point-of-care tenofovir testing with 2 30-minute counseling sessions that counseled based on the results of those tests versus standard of care. And all of this was done virtually. Of the 31 participants in the intervention arm, 100% successfully self-administered the urine tests, and 100% reported the intervention was somewhat or very acceptable. And then what was really important was they measured tenofovir levels in the hair to see what long-term adherence was like over that 3-month period, because they did testing at baseline and then testing at 3 months. And what they found was that the increase was consistent with 1 to 2 pill increase per week. So that's actually substantial. And in 6 of 8 intervention participants who had less than 4 doses a week, they wrote that after having the urine tenofovir testing, they now had levels that were above 4 doses per week. And that was not true for any of the control participants. So it did seem in this pilot study that point-of-care urine testing could be helpful as part of an abbreviated counseling intervention. And so the investigators in this study were calling for larger studies with using different methods of counseling to make it as scalable as possible. Let's turn to talking about Cabotegravir, which we know long-acting Cabotegravir administered every 2 months is quite highly effective in preventing HIV infection. Kaiser Permanente Northern California and the Mid-Atlantic Kaiser Permanente, which covers Washington, D.C., Maryland, and Virginia, have combined over 5.4 million users. And they started implementing Cab-LA in Northern California in May of 2020. And in the Mid-Atlantic in March of 2023. What you can see here is that of the 23,000 PrEP users during the study period, fewer than 1% were prescribed Cab-LA. So while it looks like the numbers are taking off, they're taking off at a fairly slow rate in terms of the total proportion of people on Cab-LA. On the other hand, they did seem to be reaching people who might not otherwise use Cabotegravir. So compared to oral PrEP users, Cab-LA users were less likely to have commercial insurance and more likely to be Black, Latino, to have had a prior bacterial STI, or to have hypertension. And if you look at this table on the figure on the left and the table, the cumulative probability of persisting on Cab-LA at 6 months in this situation was 88%, and at 12 months was 75%, which is obviously substantially better than what we saw in the national data with oral PrEP. And of the 35 individuals who discontinued Cab-LA, 34% had oral PrEP prescribed after stopping Cab-LA, and then only a few people had oral PrEP prescribed during Cab-LA use, which can be used to bridge people if they're late for their injections. So the authors concluded that Cab-LA uptake was low, but persistence was high, with over 90% on-time or early injections and no incident infections in the people who had started Cab-LA. Cab-LA is reaching people who are underserved by oral PrEP. And in particular, 24% of the Cab-LA users had no history of oral PrEP at Kaiser. So they were actually capturing not just converting people who were on oral PrEP over to Cab-LA, but capturing an entirely new population, which is great. Real world data does guide implementation. And so they did find that late injections were more likely after the first dose because you need a loading dose at 1 month. And so that needs perhaps a little bit closer attention to be sure people do come in at 1 month for their second loading dose. And then we need to counsel on bridging and switching from Cab-LA to oral PrEP. There was another study of CAB rollout in Brazil, which was really an interesting presentation. There were 6 PrEP clinics in 6 Brazilian cities and that participated in this study. To be eligible to participate, you had to be a man who has sex with men or transgender or non-binary, HIV negative, 18 to 30 years of age, PrEP naive, and either seeking PrEP or HIV testing. All of the participants in these 6 clinics had the choice of Cab-LA or oral PrEP, and 83% of them chose Cab-LA when given the option between the two. Compared with PrEP coverage, they compared this with PrEP coverage in 14 other Brazilian PrEP clinics. So I'll show you those data in just a minute. In those other Brazilian PrEP clinics, only oral PrEP was available. And then they defined adherence as being at least with less than 2 weeks late for initial or subsequent injections of Cab-LA, and oral PrEP is having enough pills for at least 4 doses per week, which is what we think is needed for maximal protection. So here is the adherence. It was 94% overall, and it only dipped as low as 92% through 13 months of follow-up. So really high adherence to on-time injections. And then on the right-hand side are coverage levels, and the blue lines, each of the horizontal lines is an individual. When it's blue, it means that the days are covered by PrEP. And when it's orange, it means that the days are not covered by PrEP. And what you can see is that Cab-LA had 95% coverage of time in the people who had chosen Cab-LA, compared to only 58% coverage of days with oral PrEP in the study itself. And then compared to those other PrEP clinics, the 14 other PrEP clinics where only oral PrEP was available, they only had 48% coverage. So the Cab-LA cohort had no seroconversions. There was 1 seroconversion for an incidence rate of 1% per year in the oral PrEP choice cohort, and there were 9 seroconversions, or an incidence rate of 1.5% per 100 person years, or 1.5% per year, basically, in the oral PrEP comparison cohort. So not only were more days covered, but there were also no infections seen in the Cab-LA arm. Now, only 6% were lost to follow-up, and only 3% required Cab-LA reloads, so because of delayed second doses. So that all just looks really remarkable, what they were able to do in this Brazilian study. There were some switches. 9% of people switched from oral PrEP to Cab-LA. And the main reason for that is that they didn't want to take a daily pill. And 4% of the people on Cab-LA switched to oral PrEP, and the main reason there was side effects, and mostly it was injection site pain. So this really demonstrates the power of Cab-LA, but also the importance of choice. Let's turn to talking about how we routinely screen for HIV breakthrough infections in people who are getting Cab-LA. And these data came from the HPTN-084 study, which was a study of cabotegravir versus tenofovir FTC in women in Africa. In the blinded phase, everybody got either actual CAB-LA and a placebo tenofovir pill, or placebo tenofovir, placebo CAB-LA and the actual TDF-FTC pill. And when the study was stopped early because it was found that CAB-LA was actually superior to TDF-FTC because adherence was not great in the TDF-FTC arm. So at that point, everyone was rolled over into an open label extension and given the choice of taking either CAB-LA or TDF-FTC. And again, 78% chose CAB-LA. So you can see that when choice was available, here as in the Brazil study, most people chose CAB-LA. In the randomized control part of the study, people were tested routinely for HIV using 1 to 2 rapid tests and an antigen antibody test at each visit. But HIV RNA was only done at screening. So the question became, should we be doing HIV RNA at each visit? Because we know that some people take longer to seroconvert when they're on CAB-LA. And so you may miss some infections if you only do rapid tests or antigen antibody tests. And so that was the big question that was asked in this presentation. Now, there were almost 2,500 participants, which included 1927 on CAB-LA and 535 on TDF-FTC. There were over 24,000 RNA tests, over 20,000 of those on CAB-LA. And of those 24,000 tests, 87 had at least one reactive HIV test. 8 of those, so 8 out of the 24,000 RNA tests had confirmed HIV. 4 of those had only had an isolated RNA test, so would have been missed if they hadn't had the RNA testing. 3 of those were on CAB-LA, and there was no integrase inhibitor resistance. 77 of the 87, or 88%, were found to be HIV negative. 12 of those had an isolated RNA positive. So you can see that there was a 3-to-1 ratio of false positives to true positives on the isolated RNA tests. And 5 of the 12 who were actually negative, who had a false positive test, had CAB-LA delays of more than 10 weeks while they were waiting to sort out whether or not somebody was infected. So during that period of time, they can actually be at risk for acquiring HIV. So there is a cost to doing these RNA tests. And they were unable to differentiate true positives from false positives based on quantification of RNA. So the authors concluded that we should really consider the costs and the risks in developing testing algorithms. And I would say that the HPTN-083 study that was reported last year also found high rates of false positive tests, where the positive predictive value was only 9% if somebody was actively on CAB-LA. So we're not recommending right now that RNA testing be done routinely to screen people who are on CAB-LA. What happens with breakthrough infections on CAB-LA? Well, this was a study that drew nationally. There was a call put out to refer people who had breakthrough infections on CAB-LA. There were 7 people referred to this study. 6 had had on-time injections. So CAB-LA is not perfect, even with on-time injections. Sometimes there are breakthrough infections, although this was a fairly rare event. 5 of those actually had protective levels of CAB-LA, so we're not really completely clear why they became infected with cabotegravir on board. 4 of them had non-reactive HIV antigen antibody tests at the first detected HIV RNA positive results. So again, you are going to miss some people if you don't do the RNA screening. So it's this balancing act between the positives of trying to find people early, but the negatives of chasing a lot of false positive tests. 5 of those had integrase inhibitor resistance mutations. 1 was high frequency, and 4 additional ones had just low frequency resistance on a very sensitive research assay. All 7 of them were started on a darunavir-based antiretroviral regimen, and they've achieved viral suppression of less than 20 copies per mil. 3 of those that had the low frequency resistance mutations ended up getting switched to an INSTI-based antiretroviral regimen, and they maintained viral suppression at 13 to 31 weeks. So the authors here concluded that long-term follow-up is needed to determine the clinical significance of low-frequency resistance mutations to integrase inhibitors and the durability of viral suppression on integrase inhibitor-based antiretroviral treatment. And there was another presentation on breakthrough infections on CAB-LA that came from the HPTN 083 study, which was the study in men who have sex with men. And this was the second question that I asked at the beginning of the presentation. What was the rate of viral suppression on the initial regimen? And the answer was 77% achieved viral suppression of less than 50 copies. 71% of those who were started on an integrase inhibitor and 81% of those who were started on a non-integrase inhibitor as their initial regimen were virally suppressed. And then there were a handful of additional people who didn't meet the definition of viral suppression, but had very low levels of virus. 5 of the people on the non-INSTI regimens were ultimately switched to an INSTI-based regimen. 4 of those suppressed, and 1, it wasn't known what the outcome was. Now, the testing, sites might have done their own testing, but this is testing now that was done in batch testing centrally. 41 participants of the 47 had resistance testing available. 9 of those, or 22%, had integrase inhibitor resistance prior to treatment, and all of those suppressed. 8 of them had been started on a non-INSTI regimen. 1 was started on an INSTI regimen and had a mutation, but still achieved viral suppression on an INSTI-based regimen. 2 of 3 without genotyping results failed to suppress, 1 each on an INSTI and a non-INSTI regimen. And so the authors of this presentation concluded that there were similar results for INSTI and non-INSTI regimens, but that longer term follow-up is needed. And so generally, people are at least trying to test for resistance mutations before deciding what regimen to start people on, but are often starting with a non-INSTI-based regimen and then sometimes converting them to an INSTI-based regimen. So let's talk about some exciting new data on new regimens. The first one was on TAF-FTC in cisgender women. So TAF-FTC is approved for use against sexual exposure to HIV, except for receptive vaginal sex, because it had never been tested before. And the Purpose 1 study that tested lenacapavir also tested FTAF. The primary outcome analyses were both lenacapavir and FTAF compared to a background HIV infection rate that was determined based on women who came into the study who were already HIV positive. And then the secondary analysis was to compare them to FTDF oral daily use. These were the results of that primary analysis. And what you can see is that the FTAF had an incidence rate of about 2% per year, which was not significantly different from the 2.4% background rate of HIV infection. But it also wasn't different from the 1.69 rate in FTDF. And we know that FTDF does work for cisgender women. And so the question was, why were these rates no better than the background rate? And the answer comes out to be largely adherence. And so what you can see here is that high dose is shown in the green, and medium dose, 2 to 3 doses a week, is shown in the yellow. And those really declined over time. This is going from early in the study to late in the study. And you can see that it really declines over time. And so, and if you do an even deeper dive where each of these rows is a different participant who becomes infected, and the time that they become infected are shown by these dots at the end of the line. The light green color is low doses of tenofovir measured in the blood. The medium green is the medium doses of 2 to 3 per week, and the dark green are high dose adherence. And what you can see is that for most of the women, they had very low levels of tenofovir in their blood just before they became infected. And so this was an adherence issue. And you can see here where they compared people who acquired HIV to people who didn't acquire HIV. Even though the adherence was bad in the entire cohort, it was really bad in the group who became HIV infected. And that was very similar to what was seen when FTAF was studied in men who have sex with men and transgender women. And so they calculated that the HIV acquisition risk was 89% lower in women who took at least 2 pills per week. So the hope is that FDA will look at these data and recommend that FTAF can be used for receptive vaginal sex, which it currently is not recommended for. The other question that comes up for women is, what about 211 or on-demand prep around the time of sex? We know that tenofovir is lower in female genital tract tissue than it is in rectal tissue, and the female genital tract is shown in green, and the orange or red is the rectal tissue. The only place where it's higher is in the active metabolite of FTC, but that wanes really quickly. So we think that you may need higher levels of tenofovir FTC in the blood in order to achieve active PrEP protection. And that was actually shown in this modeling study in which this is for transgender women and gay and bisexual men who have sex with men. Even with 2 to 3 pills a week, there was about 99% protection in that population, but it was substantially lower for cisgender women. It was still around 90% if they took 4 to 6 doses a week, but they only got to 99% when they were taking 7 doses a week. And so this was a study in which Mackenzie Cottrell looked at what you can see that the levels of tenofovir come down much more quickly in the female genital tract than in the PBMCs or the white blood cells and in the rectum. And based on these data, she predicted that 211 PrEP, or 2 pills 2 to 24 hours before sex, 1 pill 24 hours later, and another pill 24 hours after that, would provide 85% protection for 5 days after sex. And that protection would increase by 8 to 15% if you use 2111. So add 1 extra day of TDF-FTC in using on-demand PrEP. And so she proposed that this should be explored in clinical trials, and we hope it will be, because it would be nice to have an on-demand option available for cisgender women. These were data from the Purpose 1 study, in which they were looking at preferences for lenacapavir versus a daily pill for PrEP. And this comes from Purpose 1. And at baseline, about 2/3 said that they would prefer a twice yearly injection, and 3/4 maintained that preference through week 52. 29% preferred a daily pill, and about half of that group maintained preference through week 52, and 4% said they had no preference. Now, at week 52, half of those who had had a preference for pills actually switched to twice yearly injections, and half of those who had no preference switched to twice yearly injections. So you can see that people changed their minds and then wanted to opt for twice yearly injections. And also about 60% said that they had greater confidence in their ability to maintain adherence and to feel more protected with twice yearly injections compared to a daily pill. And that was before the results of Purpose 1 were known. So women were feeling more comfortable with protection and adherence with the twice yearly injections. And so this really demonstrates the importance of choice as preferences change. Then there were some really exciting data about once-a-year lenacapavir, which would be really exciting to have a PrEP option that only needed to be administered once. Now, it was a large dose. It was 5,000 milligrams intramuscularly. In the Purpose 1 and Purpose 2 studies, it was given subcutaneously, and one of the issues there is that it creates nodules. This was administered intramuscularly, but they were 5 ml injections, 5 ml injections in the gluteus. And they followed people over time, and here's what they found. The green line is the once yearly injectable, and this was using 5% alcohol to make it less viscous. And this one used 10% alcohol to make it look less viscous, And you can see that for both of them, the once yearly lenacapavir formulation actually achieved higher levels than the twice yearly subcutaneous lenacapavir injections. And so it's possible that you could even come down on the dose and still achieve very high levels of efficacy with a lower level of dosing just once a year. What about pain? Here, there's this scale that goes from no hurt at all to hurts a little bit to all the way up to hurts really badly. No one had the hurts a whole lot or hurts worse. But after they gave the injections with formulation 1, which was the 5% alcohol, you can see that there were probably more pain on the second day, but it had really resolved by day 7 and completely resolved by day 15. This was formulation 2, and one of the things that they did with formulation 2 is they randomized people to either get without ice or with pre-treatment with ice. And what they saw was that they had much less significant pain when they pre-treated these individuals with ice. So that's a good lesson to when this becomes available to pre-ice to reduce the risk of side effects. And then there was some really exciting data on in situ forming implants, which are these injectable biodegradable copolymers that you can remove. And so then they have a short PK tail. One of the issues with cabotegravir and probably with lenacapavir is that because they last for a long time, at some point, the levels will be too low to provide protection, but high enough to select for resistant virus. And so here you can actually remove them. And so there's a very short PK tail. Now, there were 2 presentations done. One was a poster in which they showed that using cabotegravir in these in situ forming implants provided 100% protection in a rectal challenge study in non-human primates, sustained delivery of cabotegravir for about 6 months, and it was well tolerated for over a year. The study I'm going to go into a little more depth with is using a multi-purpose technology, which means combining not just cabotegravir, but also a hormonal contraceptive. And what they used is medroxyprogesterone acetate, which is what's used in Depo-Provera. And what they found was that there were high and sustained concentrations for over 180 days. And this was studies done in mice. And what you can see here is they took 6 animals, and half of them, they took the in situ forming implant out at 3 months, and for half, they left it in. And what you can see is that the levels of the progesterone dropped substantially, and there was a rapid return to ovulation within 2 to 3 weeks following the removal. So this would be really reversible in terms of its contraceptive effect. But it also was reversible in terms of its cabotegravir. There was this rapid drop in plasma cabotegravir levels to below the limit of quantitation following removal of the in situ implant, whereas it stayed high if you left the implant in place. They also wanted to look at tolerability, and these were the 3 animals that had the implants in place for all 6 months. They had no local skin reactions. There were some mild skin reactions in 2 of the other animals, and then one of the animals had recurrent adverse events with more severe local skin reactions, but they resolved within a week after nonsteroidals and antibiotics. And they also showed that the X-ray demonstrated that when they were removed, they were completely removed. So they were easy to take out. And that also the ones that stayed in did not migrate through 6 months. So the authors felt that this warrants trying to pursue Cabotegravir, these multipurpose technologies with MPA in situ implants in women. Okay, now we're going to shift gears and start talking about bacterial STIs. This was an interesting study on screening for syphilis and HIV in the emergency department. And one of the reasons to screen in emergency departments is that people, you might capture people who don't seek regular care. So you might be able to catch people who otherwise wouldn't be diagnosed. And so this hospital instituted screening for all emergency department patients under 65 years of age. And then they looked 2 years post-implementation. They did a chart review to determine how many cases of new syphilis and HIV diagnoses they saw, and what would have happened had they limited their screening to just subgroups. And so what they found is that if they had limited screening to only those who had blood draws for other reasons, they would have missed 17% of new syphilis cases and 24% of new HIV diagnoses. Another recommendation sometimes is, well, maybe anytime you get a CBC, you should test for HIV and syphilis. And there they would have missed 24% of the cases of syphilis and 33% of the cases of HIV. And then looking at those who had gonorrhea or chlamydia testing, they would have missed 76% of syphilis cases and 69% of HIV. So they concluded that all targeted screening is going to miss a substantial proportion of new diagnoses, and that universal screening should be considered in high prevalence communities. Then there was an interesting presentation on treatment of syphilis in pregnant women. For women who are pregnant who have late latent syphilis or syphilis of unknown duration, the only recommended treatment is benzathine penicillin G in 3 weekly doses. The gold standard is 7-day intervals between the injections, but earlier data have suggested that you've got wiggle room, so 6 to 8 days don't lead to more congenital syphilis. The CDC STI treatment guidelines, however, implied that intervals of up to 9 days are acceptable without having to restart the full 3-dose series. And so this group wanted to address that. And so they analyzed 3 groups from California surveillance data from 2016 to 2023. Those who had adequate treatment, that is 3 injections at 6 to 8 day intervals. The second group were those who had at least 1 9-day interval between injections. And the third were group that had either no or inadequate treatment. And then they looked at how much congenital syphilis they saw. And they saw that in the group that had adequate treatment intervals, there was a congenital syphilis incidence of 5.6%. But if they had 1 or more 9-day intervals and no intervals outside of 6 to 9 days, the congenital syphilis rate was 18.2%. The odds ratio compared to having adequate treatment was almost 4 times higher, and the p-value was highly statistically significant. Those who had no or inadequate treatment had the highest rate of congenital syphilis, 36.8%, with an odds ratio of 9.8 compared to adequate treatment. So they concluded that data on the topic is otherwise lacking or non-existent, and that an RCT, including a 9-day arm, will never be conducted, so that we should given the lack of data otherwise, and while awaiting larger studies with higher statistical power, clinicians should consider erring on the side of caution and avoiding intervals outside of 6 to 8 days of benzathine penicillin G for pregnant women. And then there were several presentations on Doxy-PEP, and I'm going to show you 2 of them. One was in the setting of the San Francisco AIDS Foundation's Magnet Clinic, which is a large sexual health clinic in San Francisco that has over 6,000 unique patients seen in 2024 and a diverse clientele. They actually diagnosed a substantial proportion of all of the cases of early syphilis, gonorrhea, and chlamydia in the city. And so what they did is they looked at the cascade of Doxy-PEP from prescribed, from being eligible all the way to being adherent to it. They looked at magnet patients with at least 2 visits between December 2022 and December 2024, and they had to have an indication for Doxy-PEP using the San Francisco Department of Public Health guidelines that came out in November of 2022. And here's what they found. They, of all of the people who had a Doxy-PEP indication, 59% received a prescription. And of the 59% that received a prescription, only 61% reported taking at least 1 dose. And of the 36% who took at least 1 dose, only 61% reported that they had high adherence. So that leaves 22% of the people who were eligible for PrEP actually had PrEP adherence. And so of that 22%, what they found was that the groups that were less likely to have high adherence was younger people age 14 to 29, Black and African American patients, those who are unstably housed or experiencing homelessness, and those who were living with HIV. And so those are populations in whom we need to try to do what we can to support Doxy-PEP use, particularly because those are populations where rates of STIs are quite high. Another presentation from the same clinic looked at Doxy-PEP users and compared them to, they compared what happened before people started Doxy-PEP to what happened after they started Doxy-PEP in terms of the rates of STIs. And then they also looked at that for Doxy-PEP non-users, what happened early in the period of time and what happened late in the period of time. And what they did in terms of the periods of time was for the Doxy-PEP users, they looked up to 5 quarters before and after they initiated Doxy-PEP. And for the non-Doxy-PEP users, they just used an arbitrary cutoff of April 1st because that was the median quarter of the evaluation period for the Doxy-PEP users. And I'll show you that here. This was for the Doxy-PEP users. Once they started Doxy-PEP, they looked 5 quarters before to see how much, how many STIs they had, and they looked at 5 quarters after. And then similarly, for the Doxy-PEP non-users, they just used the cutoff of April 1st, 2023, and looked at the 5 quarters before and the 5 quarters after. And here's what they saw. The red lines are gonorrhea, the blue lines are chlamydia, and the green lines are syphilis. And what you can see is that all of these were rising, some of them quite rapidly, before they started Doxy-PEP. And then once they started Doxy-PEP, there was this really dramatic decline in the rates of all 3 of those STIs. And so here's the odds ratios. Chlamydia declined by 81%, syphilis by 89%, and gonorrhea by 44%. And that's very similar to the efficacy that was seen in the randomized controlled trial. So what that's telling us is that in real world practice, we're seeing similar rates of reductions in chlamydia, syphilis, and gonorrhea as what was seen in the randomized clinical trials. But the question is, was there something else going on during these periods of time? Maybe there's another reason why the levels dropped. So let's look at the Doxy-PEP non-users. And what you see here is there was no decline. And if you look at the odds ratios, they're all 1 or above, and none of them are significant. So there was no significant decline in the Doxy-PEP non-users. And so that's the end of my presentation. And so I wanted to go back to the post-test questions, or the pre-test questions that we're going to now ask post-test. According to data from the IQVIA commercial prescription database, approximately what proportion of oral PrEP users in the US in 2021 and 2022 persisted on daily PrEP for at least 6 months? Go ahead and vote. Great. 78% of you got that it was 40%. So it was, the average time was really only 3 months. So we really need to do things to support people who are taking PrEP over time. Let's look at the next question, which, and this is the correct answer was B. So the median persistence was only 3 months in 2021 and 2022, and only 38% persisted for 6 months. And then the question is, of the 47 participants in the HPTN-083 study in men who have sex with men who were exposed to long-acting cabotegravir but who became infected with HIV, what proportion achieved viral suppression on their first antiviral regimen? Great, and 81% of you got that right. It was 77%. Overall, those with breakthrough infections, 77% achieved viral suppression on their initial regimen, including 71% of those started on an INSTI regimen and 81% who started on a non-INSTI regimen. And that is it, and we'll turn now to answering questions.
Great. Thanks so much, Susan, for a wonderful, comprehensive, and clear presentation. So we'll move now to the Q&A. Just wanted to encourage folks to enter your questions using the Q&A button. There's the first question is from Don Bruner at Roper Health Services Center. With Doxy-PEP, say a patient has unprotected sex on a Monday and takes the Doxy-PEP right after, then has sex the following day. Do they take 2 more Doxy tablets after that encounter as well? Or is 1 dose good to cover a patient for 72 hours, regardless of the frequency of sex in that time period?
Yeah, it's a great question. So the question is, given that you can get protection up to 72 hours, what do you do if people are having multiple sexual episodes? Does 1 dose cover that? We don't really completely know the answer to that. We do think that having Doxy available sooner after an exposure, that first 24 hours may be important, particularly for gonorrhea, where there is some background rate of resistance, and so maybe you need higher doses. Maybe you need higher doses because for pharyngeal protection, and maybe also just based on the PK of doxycycline and how it protects against gonorrhea, you may need it to be closer to the period of time. So generally, what I would say is if it's within 24 hours, you don't need to take another pill. But if it's longer than 24 hours, it's probably still advised to take an extra pill.
Great. The next question is from John Kevin Carmichael. Can you clarify the current recommendations for screening for HIV in persons on cabotegravir, 4th generation HIV testing, or HIV RNA, qualitative or both?
Yeah, that's a great question. And so what we think is that some people will test. So you do need an antigen antibody test, and you should get that at each time that you're giving cabotegravir. You can do a rapid test before you administer it, and you don't need to wait for the results of the laboratory-based test in order to give the cabotegravir. But it's good to do an antigen antibody test. Some people will get an RNA test at screening before they start somebody on CAB-LA. And the reason for that is you don't know whether or not somebody has had, especially if somebody's had a recent exposure. Not everybody does that, though, but that is the recommendation from IAS-USA. But if, in terms of screening people after they've started on cabotegravir, you don't need to do RNA testing, because you will pick up some people a little bit earlier, but you'll get a lot of false positive tests. And that ends up causing both a lot of anxiety, but also leaving people unprotected for a period of time, because if you're not sure whether or not they're infected, then you don't want to give another dose.
Great, thanks. And this is sort of a more nuanced question around testing from Morgan Youngkin from Boston Healthcare for the Homeless Program. regarding RNA testing while on Cabotegravir for PrEP for patients who are starting at relatively high recent risk, but not soon enough after exposure to qualify for NPEP, non-occupational post-exposure prophylaxis. What do you think of obtaining an RNA with antigen antibody screening at 1 month after the first injection, that is at the time of the second injection, and the rationale being to potentially catch people who may have started in the window period?
Yeah, I think that that's a reasonable approach if that's what you want to do, particularly if somebody's been at high risk. I think that in that situation, you probably want to get an RNA at screening because that's still going to pick up most of the acute infections. And you're not going to start CAB-LA if somebody has symptoms of acute infection, even if they are, even if before you get their test results back. So if somebody is really early in infection but has symptoms, then you wouldn't want to start them.
Great. And there's a question from Joshua Sawyer, Independent Health. When will CROI 2025 abstracts be available to non-intenders? The ED-STI abstract could be particularly helpful. It looks like the presentation slides and on-demand recordings will be available within 24 hours of this broadcast. And the overall abstracts for CROI will be available starting tomorrow, and it'll be available on the IAS-USA website. And then a question from Namrata Shah from Whitman Walker Health. Can you comment on data for Doxy-PEP use in women?
Yeah, so we unfortunately don't have data yet on Doxy-PEP in women. The one study that was done that was an efficacy trial did not find protection. But when measuring doxycycline levels in the hair, it was clear that the adherence rates were very low. And so we don't know whether or not it works in women, but it should work in women. And the reason we know from the PK data that it appears that it should work in women, that you get high enough levels in vaginal tissue and genital tract tissue to provide protection. And so many people are counseling women about counseling them that we don't have the data about whether or not it works, but if a woman is at risk of acquiring bacterial STIs, still providing them or, making available Doxy-PEP. There was a study that was going to be done within the Adolescent Trials Network to do an efficacy trial in women, another efficacy trial in women, hoping for higher adherence. But unfortunately, the Adolescent Trials Network was canceled recently. So the future of that particular study is a bit on hold. But we hope that there will be another efficacy study in women because we really do need to know whether or not it would work for women, particularly because of this epidemic of syphilis in young women. And in particular, we want to avoid congenital syphilis, but we want to avoid syphilis, period, and high rates of chlamydia in women. And we know that Doxy-PEP is very highly effective, 70 to 90% in the men who have sex with men and transgender women trials against both chlamydia and syphilis.
Wonderful. The next question is from Cheryl Thompson from Health Research, the HHS. Back on the longitudinal slide, how do you explain the dark green and medium green lines right up to the time of infection?
Yeah, that didn't happen very often, that women had high levels of tenofovir in their blood right at the time of infection, but it did happen in a few people. In some of them, there was resistance to tenofovir, so they were infected with a resistant virus. And we don't really completely understand why it happened in for all of the women, but it was fairly rare that happened. But in the same way, we saw Cabotegravir infections in people who had on-time injections and high doses. So neither of these regimens is 100% protective.
Great. And then there's a question from Sue Klassen. If women use Doxy-PEP, what about the adverse effects of Doxy on pregnancy and how to be assured she's not pregnant?
Yeah, so there is concern about doxy in pregnancy, although people do think that doxy is different from tetracycline because tetracyclines should not be used in pregnancy, but there is some question about whether or not doxycycline can be safe in pregnancy. It's still listed as being contraindicated. And so you would want to, again, counsel women. And if you, you want to counsel women and probably the issue is they need to be counseled about the potential hazards of taking Doxy-PEP during pregnancy. And so you would counsel them to try to avoid pregnancy while they're on Doxy-PEP.
Great. It looks like there aren't any other questions, so we still have a few more minutes if folks want to enter questions. There were a few pre-registration questions that we got, and so I was going to ask a couple of those. First, from Olga Lopez, was a question about when to expect approval for long-acting injectable PrEP that's every 6 months, and also how feasible do you think it is to globalize the PrEP strategy with lenacapavir?
Yeah, so lenacapavir is currently undergoing FDA review, and we're supposed to hear by late June, if everything goes on schedule, about whether or not it's approved for use. It'll take some time then for it to roll out after that. I think that there were commitments made to try to disseminate lenacapavir globally after its approval. Those are somewhat in question just because of what's going on with funding globally for prevention. But our hope is that that will still be rolled out globally because there were no infections in women in the Purpose 1 study. So although there was fairly short follow-up, it was still very highly effective. And we know that adherence to a daily pill is quite difficult in the settings in which women live in Africa and in many of the settings. And so many of the women do have difficulty taking a daily pill. And so a twice-a-year injection and ultimately, hopefully, a once-a-year injection would really potentially drive down infection rates in very vulnerable populations.
Great. And a comment or a statement from Rona Vale, more of a statement. For TAF-FTC, there was only 2 women who seroconverted taking 4 or more doses per week, and 1 had resistance.
Yes. So thank you for that comment. It's true that it was there were only 2 women who had 4 doses a week, and one of them did have resistant virus.
Great. And there's sort of a related question from the pre-registration, James Bell from the LA LGBT Center. Wanted to get your opinion on using Descovy or TAF-FTC for 211, and also use of daily Descovy for a person's AFAB, assigned female at birth, for folks who can't tolerate Truvada or prefer an oral medication.
Yeah, so in terms of on-demand PrEP using TAF-FTC, we know that TAF-FTC does have a quicker onset of action. So there's currently a study underway using, rather than 211, using 1-1, 1 dose before and 1 dose after. And so we hope that we'll have results from that study before too long and that we could actually recommend using TAF-FTC as well for on-demand PrEP. The other question was about
Daily Descovy.
daily Descovy for women.
Yeah.
I think given the data that were just presented, that it is a reasonable option to provide, even though it's it's not yet FDA approved, so you need to counsel that it's not FDA approved. For women who aren't able to tolerate TDF-FTC, using TAF-FTC is a very reasonable alternative, I think.
Great, I agree. And then there was a question from Teresa Rousseau from University of Pretoria. What do we know about changes to the microbiome with long-term doxycycline treatment?
Yeah, so There was actually a presentation at CROI this year on Doxy-PEP. So that was daily Doxy. And what we know is that Doxy-PEP, which is what we're recommending, generally people are taking about a pill a week, 5 to 7 pills a month in the studies that have been done so far. So a little more than 1 pill a week rather than a daily pill. What we've seen so far is that there is increased resistance to gonorrhea, an increased expression of gonorrhea resistance genes in individuals who are on Doxy-PEP. It doesn't look like there's a substantial effect on the microbiome, the rectal microbiome, in these studies. But there's more work that needs to be done, and it's quite complex to even understand how to study the microbiome. But it looks like for the major changes that would be potentially expected, that we don't see them. Now, what we have to remember is that doxycycline is in so much of what we eat. It's in the animal products because it's used quite widely in agriculture. And so we're getting exposed to doxycycline through other means as well. And so that may be why there's no difference between the people who are on Doxy and the people who weren't on Doxy.
Wonderful, thank you. And then maybe one last question from Holly Van Loo from the Indian Health Service. Can you provide updated information about the use of the Bexsero meningococcal B vaccine for gonorrheal prevention?
Yeah, so last year at CROI, we had the presentation from Jean-Michel Molina that the Bexsero vaccine, which was being used to try to prevent gonorrhea, was not effective, not statistically significantly better, but there was a sort of trend towards a potential minor effect of something like 22% or something, if I'm recalling it correctly. There wasn't any presentation this year, but there is a large-scale trial going on right now that's a global trial in both men and women using the Bexsero vaccine to try to prevent gonorrhea infections. And we should have results sometime. I probably won't be until next year.
Great. Well, it looks like there aren't any more questions. So thank you so much, Dr. Buchbinder. That was an amazing presentation and discussion. I think we'll move to just a few closeout slides. The evaluations and information on how to collect continuing education credits will be emailed to you by 5 p.m. tomorrow. So keep an eye out for that. I want to highlight a few on-demand podcasts as well as upcoming activities. So there's the Golden Antiviral podcast hosted by Michael Sogg, and there's one on bacteriophages, which looks really interesting. On April 23rd, there's HIV drugs on the horizon, what's new in 2025 by Melanie Thompson. And then May 13th, there'll be a latest update on urgent viral outbreaks in spring of 2025. And in May 20th, there'll be a virtual course on keeping up with the guidelines, recommendations, and controversies in STI management, which looks really exciting. And then finally, also save the date for a conference on bacteriophages in Washington, D.C. In October. And with that, we wanted to thank you so much for participating in this webinar. Thank you so much, Dr. Buchbinder, for the wonderful presentation and answers to all our questions. And also thanks to the IAS-USA and our hosts for putting on this webinar. And take care, everyone, and thank you very much.